you, and say welcome to our third and final webinar in our series leading up to the Type 2 Diabetes Dialogue Day in November, 2 days. So this session today will be a spotlight on innovation, focusing a special focus on the Abbotsford and Pacific Northwest divisions of family practice. So, as always, I'm going to begin by just acknowledging how lucky I am to live, work, and play on this beautiful land each and every day. So I would like to express my gratitude and acknowledge that I am joining you today from the traditional, ancestral, and unceded territory of the Coast Salish, Nooksack, Kwantlen, and Stalo nations. Feel free to pop in the chat what nations you are joining us and do your own territorial acknowledgement if you'd like. You could do that in the chat. So with that, my name is Raman Bowerbank. I am a leader of health system improvement with the BC Patient Safety and Quality Council. I am passionate about change in our healthcare system and beyond. I am also a daughter, sister, friend, wife, and a mother. I will be your host for today's session alongside my partner in crime, Shauna Nickel, who is more of the technical wizard of making it all happen today. So feel free to message her or myself in the chat if you do encounter any audio, video, or any kind of technical Zoom issues. And speaking of Zoom, this is going to be brief because we all are pretty pro at using Zoom, but just a FYI that you are on mute and your video is off when you join. We invite you to turn your video on today. We would love to see your faces while we present. And if you could stay on mute until the Q&A, that would be great, just to avoid background noise. But during the Q&A, feel free to unmute your line and ask a question. In the meantime, you can post all your questions and comments into the chat box. And with that, we will get right into our first presentation from the Abbotsford Division of Family Practice. We have Danielle Edwards joining us. So Danielle is a programs lead for the Abbotsford Division of Family Practice and has been collaborating on health projects for the past decade. She has a passion for preventative health, quality improvement, and community health initiatives. We are very excited to have you, Danielle, and I will pass it over to you.
Great, thank you so much. Can you hear me okay?
We can, yeah.
Great.
Thanks.
Okay, perfect. Can you see my slides okay?
Yes, we can.
So thank you so much. I wanted to note that the Abbotsford Division of Family Practice is a nonprofit society. We support family physicians and the health initiatives they lead and engage in order to give some context to my presentation today. It's a great privilege to be able to dialogue with you today about a pilot in Abbotsford that demonstrated that having team-based RD services or registered dietitian services within family practice clinics can provide great value, great patient care, and great access with limited costs. I'm also pleased to note that largely based on the pilot outcomes, and the pilot started in 2015, we now have a full-time RD role funded through Fraser Health Home Health to provide this team-based care. So my overall goal of the presentation is to discuss and highlight what elements can make team-based care successful. I hope that through today's discussion that you can then ponder, tweak, and apply some of the learnings in your current or future work. So this will be my presentation outline, and I will get started. So some background to the pilot. So Abbotsford has a high incidence of low to moderate chronic disease, like diabetes and hypertension, that can be managed and offset through the preventative clinical care. Part of this care includes access to nutrition counseling provided by an RD. And as part of the A GP for Me initiative back in 2015, the Abbotsford Division partnered with Fraser Health Nutrition Services for a team-based care initiative. And this was from September 2015 to March 2017, where we tested the utilization of a full-time Fraser Health RD within family physician clinics. The team-based care pilot had 4 RDs, totaling 1 full-time equivalent employee, who provided care at 10 clinics serving the patients of more than 30 family physicians. family physicians could triage patients based on need. And while prediabetes and diabetes were common reasons to see the RD, there was a range of other health conditions that were cared for by the RD, including celiac disease, irritable bowel syndrome, and digestive health issues and weight gain. We collected evaluation data to assess the team-based care pilot, and I'll highlight some of these outcomes on the next slides. So on these slides, you can see some of our healthcare outcomes. Aggregate health outcome data was collected from 4 of the 10 clinics involved that had received consistent RD services over the 19 months of the program by the same RD. Our pilot's outcomes reflect national averages reported by the Dietitians of Canada for nutritional services. And we were very pleased about the results. On this slide, you'll see the patient experience. And this was collected through surveys and interviews. Many of the patients who had struggled to lose or gain weight on their own felt supported by the RD to make long-term lifestyle changes, and they felt that these changes were realistic to continue with. Patients indicated that they valued the one-on-one tailored supports, and seeing the RD in the familiar location of their family practice clinic supported their attendance. They felt responsibilities to show up at their physician clinic for visits and to make those health changes. And also, we had very low no-show rates. Patients explained that the top health benefits of seeing the RD at their physician's clinic were improved diabetes management knowledge, weight loss, and improved blood glucose control. Physicians were also happy with this program. Physicians could easily triage patients, have immediate communication with the RD because the RD was in their clinic. Patients were seen in a timely manner, and value was found in nutritional counseling as preventative healthcare and chronic disease management. One of the challenges that was identified is that clinics carried the cost of overhead to house an RD. And through the now primary care network communities who have RDs, some of this overhead costs can be supported. But again, we were doing this work pre-PCN. We also surveyed clinic MOAs, and 100% said that the RD appointments ran on schedule. They liked that patients who had transportation or financial barriers could see an RD in-house. That they said that there was less wait times to see an RD in the clinic than if they had done a referral because of the times that it can take for referral processes. And so overall, providing care within the family physician clinic setting was seen as beneficial to patients, staff, and to family physicians and the RD. On this slide, you'll see we did a cost analysis. So the Dietitians of Canada report notes that for every $1 spent on nutritional intervention can save the health system between $5 and $99. So applying this measure to the project where we invested estimated $140,000 gives us a projection of healthcare cost savings of $700,000 to $13.8 million. The evaluation and cost savings formed the bulk of our analysis, and we produced a more detailed report titled A Case for Prevention, Registered Dietitians Impacting Upstream Primary Care in Abbotsford. And I would be happy to share this with interested participants. When reflecting on what makes team-based care pilots successful, having a system to monitor, collect, and report on evaluation data is important in order to identify and work through barriers and leverage successes. And so I was hoping we could pause for a moment and reflect on the following question. What makes team-based care successful to you? This may be from the perspective of a provider or a patient or a family member. Maybe you know about a team-based care project or working with such a project currently. Let's take a few moments to note this on the whiteboard.
And Shauna has popped into instructions on how to get some text onto the whiteboard in the chat.
It's great. We have some feedback coming in. And feel free to put your feedback on here. So this feedback is looking great. We have building on each other's clinical strengths, trust, collaboration, communication, wraparound care focused on the patient, great outcomes. It's great feedback. Thank you. Just share my screen again. Perfect. Here are some successes that stood out that made the team-based care pilot successful. And a lot of these elements will touch on what you've spoken to and wrote down. So team-based care can bring organizations together that may have not worked together in the past or not worked together a lot in the past. And so when two or more entities are coming together, you can become almost a third entity. And having individuals come together working towards a similar vision, we found was really important. That can make that group from different organizations or just different groups become more of a team because you're striving towards similar goals. So we had a lot of discussions around the vision and the goals. What kind of outcomes were we looking for? What did we want to track and measure very early on? And that developed over time, but those were important discussions and conversations. Another success we found is having people that are collaborative, supports launching and implementing team-based care. And so by collaboration, I mean people that are willing to work flexibly, be adaptable, working for that greater good or vision, having healthy differences of opinions really important, and being able to respectfully discuss and work through that. And also promoting the program where needed and seeing how we can grow the program and tweak that program. And this feeds into having a team-based care skill set. As part of the hiring process for our future permanent RD, we developed a list of important team skills. And as you can imagine, the RD is working in multiple clinics that have different clinic cultures, if you will, processes, personalities, dynamics, and navigating this and also becoming part of that clinic team requires additional and unique skills. And so we developed that as part of the future RD role. Regular communication was also important. So what started off as more structured and set meetings became more as needed phone calls and text messages as those working relationships developed. And with any pilot, things can and do change, but having a project lead or contact person to organize the work, set clear roles, and plan ahead was really important. And it sounds simple, but having a key contact person to forecast what's coming up supported the scheduling of key meetings, supported scheduling the RD at clinics, determining when and how often and how best to communicate with physicians and other stakeholders, and supports the overall well-functioning team members. And evaluation is also important because this will allow you to capture and discuss learnings and barriers and also to demonstrate leverage and celebrate success. So just to note that there was a lot of planning that went into this and a lot of people who opted into wanting to be part of this project because they wanted to reach towards that similar vision. So the current program, delighted to say in 2019, we have a full-time permanent Fraser Health Home Health RD providing care in family physician clinics. In 2018, after the pilot had ended, it kind of stalled and we presented our case and our evaluation to different members in Fraser Health, and we are delighted to have a permanent RD. You can see in the corner there, our permanent RD is Kirsty, who's wonderful, and she developed a poster that clinics can put up on their TV screens in their office, hand to patients, circulate electronically, and that supports the physicians and the patients getting to know her, and also describing the program. We continue to look for ways to support clinics and the RD. And so you'll see on one side of your screen, it's not legible, but I just want to note, these are a lot of the health conditions that the RD can provide care for and support. So again, pre-diabetes, diabetes is the most common, but there's a range of other health conditions. And so wanting to let family physicians and patients know about that. It also provides physicians with information on who to refer to when some of the health conditions would be out of scope for the RD. So for example, to a pediatrician or for more chronic eating disorders where there's some supports. And Kirsty also developed great tips on the physician conversation with the patient about the referral, you know, if they're ready, if this is something that they would want to do and engage in. So we're just to make the note, we're always looking for ways to make improvements. We continue to evaluate the program. We just closed another patient survey, and the program is seen as quite valuable. Continue to have increased satisfaction with the family doctor clinic, changes in health behaviors and health improvement, which is great. And this is my second to last slide. I wanted to note that the current state of the program. So as a team, we've been navigating during COVID-19. The RD care has shifted to virtual and phone visits for safety concerns and protocols. This model has increased RD capacity. So for some days she would be traveling between clinics to see patients, and now she would have that travel time where she could see patients. And the patient feedback about virtual care has been overall positive. For example, patients don't need to worry about transportation. There is a bit more flexibility in the RD schedule. But patient also really valued the in-person visits too. It was noted as more personable, and it was a great way to get to know the RD in person, rather say through a phone call to meet someone for the first time. But overall, patients are very understanding, and similar to how we're doing a webinar today, rather say than an in-person conference, a lot of things in life have shifted to virtual. And so there's been a lot of understanding with that and appreciation that we've been able to continue the program in spite of COVID. So it was a real pleasure to be able to dialogue with you today. I wanted again to provide an overview of our team-based care pilot, to how we got here, some successes, and then where we are today. So if there's any questions, I'd be very happy to respond. Thank you.
Thank you so much, Danielle. That was great. We do have a question in the chat box, and feel free to pop any questions or comments in, and we will get to those. So the first question is the RD at your clinic linked to eating disorder support team locally?
Yes, the individual would be connected to the resources in our community, is my understanding.
Okay. Awesome. That's the only question we have so far. But there's more coming in. So how is the program impacted by the PCNs now developed?
So we are not a PCN community yet. We are a waveless community. I guess that's what we're being called for right now. So we'll look to the future to submit an EOI, and then we will look at that time if there would be a duplication of services, or potentially how could that potential PCN community interact with the RD, but for right now, we're not a PCN community.
And then just a comment that it was a wonderful presentation, and they're wondering if you would be willing to share your report.
Definitely, and there's a few appendixes with that go kind of into a bit more lengthy of the survey analysis, and so I can definitely share that maybe with you, Raman, and then can circulate that out. Yeah, I was also reflecting on the PCN question myself. It is nice to know that we have that full-time role within Fraser Health, and we have established that relationship. And so when we get to PCN and looking, not sure how long PCNs will be for or what that projection is, and to look at how we have a few team-based care programs and how that might interact with PCN will be really valuable and interesting. And I could also keep you in the loop on that too if people are interested.
Yes, I knew there would be interest in the report. And then there's also interest in the when to refer your patients to an RD resource, if you could share that as well. And there might be a few more questions that roll in. I was just going to say, I know it was a while ago, but what would be, I guess, 2 or 3 initial steps, if you could rewind back to when you were first starting, for your colleagues, what would be the first few steps to take to kind of get into a model like this?
Yeah, so a lot of what we did was driven in both a desire by our partners and by the division members to want to engage in this. So a willingness, a desire that was also grounded in what was seen as a need and health data. So prevalence, for example, as I was mentioning, that mild to moderate chronic disease. And so I think that having that willingness and that data to kind of back that up would be a good foundation to start with. And then to think about who would be sort of the best folks at the table to be part of a committee or just a working group to begin with to look at what the vision could be, what a goal would be, some of the outcomes, almost thinking like, what would the evaluation kind of look like? What are you wanting to do differently? And how would that be an improvement to the current state? And so I think it wouldn't mean that certain people at the committee or the working group aren't supported by their supervisors, but are there key people that maybe they really gel and work well together and have the capacity, the time, it's, you know, part of their mandate, part of their mission, that would be great to have together. And, you know, that might look different for different team-based care initiatives. You'd want to bring in community services or nonprofit organizations. That would also be important to say who's at the table and who might be missing, and how can this benefit everyone involved and with that patient that everyone's serving at the end of the day.
That's awesome. So many great takeaways there. So a couple more questions. So did this work impact the way in which physicians documented clinical observations such as waist circumference, BMI, BP? So for example, observations that might be important to track to be able to show improved health outcomes.
I would have to go back and ask about that. I know that when we were doing this initiative, being able to, you know, to ensure that we were tracking that data aggregate was very important. So I would imagine that would have been top of mind, but I would have to go back and ask some of the family physicians about that. I'm not sure.
No problem. We could get back to that one then. So next question, does your RD also facilitate groups? So for example, group medical visits for certain patient groups and disease states.
Yeah. So when we had the RD working at some of our clinics, like the Abbey Maternity Group or the Abbotsford Maternity Group, we did offer group sessions, especially because of space parameters as well. And so that worked out quite well. And then I don't know what the uptake was with the group sessions after a few of those sessions. And so the answer is yes, we would do that based on, again, that need and that desire. We have found that most patients having the one-on-one is also been quite beneficial. And it may support, I'm guessing, trust or being able to have more of those free flow discussions, but the group sessions, when they did happen, worked well.
Awesome. We have time for a couple more. Have you looked at any HDC data to explore changes in health outcomes as a result of this pilot?
No, I don't believe that we did.
Okay. And next question, is the RD charting in the doc EMR?
So RD charting in the doc EMR.
Yeah,
so yes, charting in the family physician EMR, and that's the primary record of where that's kept.
Awesome. Any kind of experiences to share around that or how that went? Was it pretty seamless?
Yes, it was. So part of the orientation for the RD was to learn the different EMR systems. We have a number in Abbotsford. Some communities have like one primary one. We have a number. So there would be time spent and carved out for the RD to learn those systems. They are also not going into all the different fields though, so it does get pretty straightforward. So the handover we've had between RDs has been quite good. And my understanding is it's been very straightforward and seamless, but we did have discussions on that process. It should note too, we also have memorandums of understanding that were vetted by Fraser Health Legal. that each clinic has with Fraser Health. And so that outlines very clear roles and responsibilities, including charting.
Great, thanks for sharing that. And this might be maybe a detail in the report, but we have a question around what the data source is for prevalence in the community.
Mm-hmm. So I would have to go back to that. I believe it was local health authority data that we would receive a report on. But again, it probably is footnoted in the report from a few years ago. Yeah.
Okay, and we will end on this last question. Did the GP join at the end of every RD visit or just as needed?
My guess is that it was as needed. And there could be different reasons for that, and different physicians may have different practices with that. That was my understanding.
Awesome. Okay, we're almost at time, so thank you so much, Danielle. There's so much, and if anyone has any further questions, Danielle's around for the second presentation, so feel free to chat them in, and she can chat them the answers back. But thank you, Danielle, and thank you everyone for the engagement and for the questions. Okay, moving along, I'm just gonna pull up my slides again, and there we go. Okay. Sorry, I have too many PowerPoints open. Okay, I think everyone can see my screen now. Yes, awesome. So actually, so for our next presentation, we have two guest speakers from the Pacific Northwest Division, Jocelyn Black and Honora Odo are joining us today. They're both family physicians working in rural and remote areas of British Columbia who are passionate about primary care, prevention, and healthy lifestyles. They're going to share a bit about the incredible work they've been doing with Change BC. So I will pass it over to you, Jocelyn and Honora.
Hi, I'm just going to start screen sharing here too. Is it working? Okay, I'm Jocelyn Black. I'm one of the two GPs who are presenting today. I work here in Masset.
Oh, hi, my name is Honora. I'm one of the GP and I'm presenting with Jocelyn today.
So Dr. Odo or Honora and I do not have any conflict in relation to the Change BC program in this presentation. I'd like to start the presentation by acknowledging the 25 Indigenous communities that call the Pacific Northwest home and maintain a respectful and protective stewardship over the land. We are so grateful to be living and working on unceded territory. Our objectives we'd like to answer for you today. What is metabolic syndrome? Metabolic syndrome data in BC and how does this impact us? What is Change BC? What were the results from Change BC? Your opinion, and what are we up to now? So metabolic syndrome is when 3 of the following 5 criteria are present in a patient. That includes hypertension, high blood glucose levels, hypertriglyceridemia, low HDL, and a large waist circumference, so central obesity. Every 3 minutes, another patient in BC is diagnosed with diabetes, and approximately 1.5 million people in BC have diabetes or prediabetes. The number is expected to grow by 35% over the next 10 years. And as I'm sure we all know, diabetes contributes significantly to heart attack, stroke, renal failure, amputations, and vision loss. The estimated annual cost to BC's healthcare system is $509 million per year. So as healthcare providers, we see patients with metabolic syndrome in our practice every single day. And according to a study in 2014, 19.1% of all Canadian adults meet the diagnosis of metabolic syndrome, as I described what that was in a few slides previous. The prevalence of metabolic syndrome increases up to 40% in those who are over 65. And also is shown to, or there also have shown a high burden of abdominal obesity, low HDL, and hypertriglyceridemia in people younger, ages 18 to 49. The result of all of this diagnosis of metabolic syndrome is an increased prevalence of chronic conditions like diabetes, heart disease, and accounts for 17% of all healthcare costs in Canada and 43% of all deaths. The good news that we want to share with you today is that family physicians and healthcare providers can detect the condition using that the criteria of metabolic syndrome and treat it with Change BC, working together with kinesiologists and dietitians.
Yeah, and the question is, what is Change BC? Change actually means Canadian Health Advanced by Nutrition and Graded Exercise. It is a program created by health professionals within Metabolic Syndrome Canada, which is a national program. It is a tool for family medicine clinics to improve health outcomes of patients with metabolic syndrome through a long-lasting lifestyle intervention. It is a team-based program that involves a family physician of the participants and a dietitian and a kinesiologist. And the focus is to improve and sustain a long-lasting improvement on patients that have metabolic syndrome, with aim to reverse metabolic syndrome and prevent the potential complications. The team provides a personalized, supervised, and an integrated lifestyle program for the patient. And I want to mention that it is not a weight reduction program. This slide provides an overview of the program. It starts with assessment and enrollment of patients on the program, and it ends with analyzing the results and discussing the outcome with the patient. It is a 12-month-old program. The family physician of the patient is usually the one that identifies a patient that will benefit from the program, and this is based on the lab results of the patient and the findings on physical examination. The family physician discusses this program in details with the participants, and if the patient is agreeable to start, the family physician makes an arrangement for the patient to meet with the dietitian and a kinesiologist. During the meeting, there is a baseline assessment of this participant, of the patient, and there is a detailed information on the components of the program, the milestones, and other things that are required and needed for a patient to have a successful participation in the program. Then the group will come up with a personalized change plan and goals for the patient. After this, the patient starts the program, and in the first 3 months of this program, the patient is being reviewed every week and as needed by the team. And during each of the reviews, the progress is being discussed, and any modification that is required is being made. After the first 3 months, the subsequent months, the review is every 1 month and as needed. Apart from this regular review by the team, the family physician of the patient advises the patient every 3 months to specifically review the patient's progress, and this involves a blood test and a physical examination. The findings on each of these reviews is documented, and that is what is analyzed at the end of the 12 months, and the outcome is being discussed with the patient. Next slide, please. The program has an eligibility criteria which involves both inclusion and exclusion criteria. The inclusion criteria is grouped into 3. One of it is the age. Second is the findings on lab tests, while the third is the findings on physical examination. For a person to participate, it must be at least 18 years, and the requirements on the physical examination are the blood pressure of the patient, which should be at least 130/85, or this person is already on antihypertensive. The second factor here is the abdominal circumference of the participant, and this is based on the ethnicity and the gender of the person. The third group of criteria is the lab results. And the fourth is the fasting blood glucose of the participant, which must be at least 5.6 or 5.7%, that is the A1C, or the patient is already receiving antihypertensive medication. And the second is the fasting triglyceride that is at least 1.7, or the patient is already receiving medication for that purpose. And the third is the fasting high-density lipoprotein cholesterol that is less than 1 on a male or less than 1.3 on a female. Next slide, please. This slide has information on the exclusion criteria. It is a detailed information which I won't be able to discuss because of the need of time. But the summary of it is that the patient that is excluded from this program are usually a patient that the participation it is not safe. Like the patient cannot safely participate or safely undergo the activities that are involved in this program. And this mainly because of other comorbidities or for some other reasons. And I want you to understand that this involves a physical exercise. So the patient must be physically fit to be able to, successfully go through the program. Next slide, please. The program was piloted by 6 physicians the program is being led by 6 physicians in our region, and the pilot was done in 4 communities. These 6 physicians, they developed, and they are the ones that implemented the program in these 4 communities. And the communities are the community of Marset, Terrace, Smithers, and Hastings communities. This slide has, we need, your feedback, to help us, with moving this program forward. So the question here is, what do you feel are the key enablers for large-scale implementation of change program? So these are the options. If you can just pop some answer on the poll, that will help us. So we're going to give some seconds, for your response. So we just have a few seconds to close the poll. Okay. So from the poll, it appears physician engagement has, the highest, percentage. So engagement of physician is 74%, required for us to be able to expand this program. And thank you for the information. Can we end the poll and move to the next slide, please? Can we end the poll, please?
I think the poll has ended. The previous poll has ended, and now this is the new one.
Okay, yeah. So this is a second, question. We're trying to get, information from you on what you think are the barriers that against the large-scale implementation of this. So there are a couple of options here, and if you can just, click on the 3 topmost, potential barrier that we inhibit or that we're going to limit upscaling the project. Yes, so 75% of the respondents indicated the lack of local dietitian is a barrier. And second to that is lack of time and ability, which is 56%. The percentage or the number of people that agree that local kinesiologists and poverty are the same, and the value is 44%. Thank you for the information. So we can now end the poll.
And now you could just click on the X icon at the top.
One of the questions we had going into the program was, can metabolic syndrome be reversed? And the results at 12 months after this program was started showed that 32.4% of patients were able to reverse the diagnosis of metabolic syndrome. That means they had less than 3 out of 5 of those criteria I reviewed earlier. More data that was done showed that 78%, these are all results at 12 months after program initiation, 78% showed improvement in their blood pressure, 55% showed improvement in total cholesterol, 86% showed improvement in aerobic fitness, 64% showed improvement or reduction in waist circumference, 52% showed improvement in their fasting triglycerides, and 64% showed improvements or reductions in their fasting blood glucose level. 93% showed improvement in their nutrition knowledge, and 81% improved in their VO2 max as was measured by the kinesiologist on treadmill testing. This figure shows the reduction, the improved ProCam score. The ProCam score is similar to the Framingham in that it predicts 10-year cardiovascular risk. And this is based on risk factors like history of cardiac disease, diabetes, high LDL or low density lipoprotein, low HDL, smoking, and blood pressure.
Okay, so after the 12 months of the program, we had a survey that was conducted 1 to 2 years after the program. And this was to evaluate the experience and the level of activation of the participants on the program. And I want to mention to you that this is not just a care delivery program. It is not a weight reduction program. It is a program that is being structured to activate and to empower the participants to be able to develop the knowledge and skills that is required for them to independently and effectively maintain the impact they got from the program, and at the same time to have a sustained improvement on their health. And the 12 months period was actually considered enough time for them to be able to have these skills. And having the family physician as part of the team is a measure to make sure that these participants have a support to keep them on track even after the 12 months. So we had a report from the participants, and 100% of the respondents said on the survey actually strongly agreed that the Change BC program was relevant to them. 100% also agreed that the program have helped them to understand their health issues. 80% of the participants strongly agreed that the program has increased their knowledge of the support that is available to them, because that's an issue. Some people may not even know that the support is available to them as a metabolic syndrome patient. 61% of the participants agreed that attending a section with other patients added value to them. 100% agreed that having a dietitian, a kinesiologist, working along with the family physician added value to them. And there was, we tried to find out on a scale of 1 to 10, how much confidence are the participants on the knowledge they have to improve their health through a healthy exercise program and diet. And an average of 7.82 over 10 of the participants said yes to this, that they have had an improved, confidence on the healthy diet and, the type of exercise they can engage on to be able to have an improved and a sustained health status. The next slide, please. So this slide has information on the testimonies of the participants, and I'm just going to read them as they are. One of the participants wrote that the Change BC program was truly life-changing. Another person wrote that the Change BC program helped them to feel much better about their body and health. And another patient wrote that I feel 10 years younger after the Change BC program. So these are some of the wonderful testimonies of the participants on the program. One patient wrote that I felt supported throughout the whole process with consistent communication between me and the 3 streams of healthcare professionals. And that's the reason why we did not end measuring the clinical outcome. We went ahead to measure, what is the relationship, what is the experience, how much is the patient that participated on the program is activated. And the report is what I just, discussed with you. Now, the next thing is, why is innovation program such as, Change BC important? This is because apart from the health and other benefits to individuals, it is also a plus. It is also a source of, fund saving for the government. A study has shown that a 30% risk reduction intervention, that a 30% risk reduction intervention aimed at Canadian individuals with highest diabetic risk would save our government $1.48 billion in health system costs. This is a fund that can be channeled to other public, projects. And this shows, how important, having a program like this is to our society. Now, what does it cost, Pacific Northwest Division to run Change BC program in our region? I want to remind you that this is not the first time, this program is piloted. It has been piloted in the provinces of Ontario, Quebec, and Alberta. And the centers involved are more on, the urban part of, the province. One should expect, that the cost of, the program will be much more, less in such provinces because they have more resources being in an urban environment. But that is not the case. The cost of the program in those 3 provinces, we are about $8,400 to $8,800 per participant over the 12-month period. In our case, the cost was $8,000 per participant over the 12-month period. And some of the reasons is because the Pacific Northwest Division is innovative on their approach to the program. We started by approaching the School of Kinesiology, BC, and we partnered with them, and they were able to send their students. So the communities have piloted this program, and the students were able to provide the exercise components of the program under supervision by a hired kinesiologist. We also hired a kinesiologist that is also a dietitian, so we're able to give 2 skills in one person, and those are some of the factors that help us to reduce the cost. This slide is having information on why Change BC works. It is not a news to us that lifestyle and good diet is important for good health, and most of us actually have this information given out to our patients on a daily basis. And we have a good number of patients that are already engaged on lifestyle changes. But the question is, despite all this, there's still an increase in the prevalence and incidence of metabolic syndrome and similar disease conditions. The answer could be because maybe we are doing the right thing, but maybe the wrong way. And this is the reason why Change BC is important, and that is also the reason why the program works. Unlike most other interventions, it is a team-based approach involving the patient family physician, which is important because this patient has to be followed up after the program. So having a family physician, they're working with a team is one of the things that makes this program special. Another thing is that the participants are being provided support, during this program. So there is an ongoing support. The patients are not being left on their own. There is ongoing supervision, review, which is crucial, to the success of the program. So the program also involves a personalized change plan. Because of other comorbidities and lifestyle that are different, having a patient, come together to have a personalized plan is one of the ways that this program is making a huge difference. It is a 12-month program. It is not 3 months. And 12 months is considered enough time for a patient to learn the skills and have the knowledge that is needed. And another thing is that we start the intervention in a gradual way. We don't start bombarding patients with a lot of changes, and that helps patients to adapt and tolerate the necessary changes that are needed for the program. And I have to say it again, the regular check-in and support the participant receive is also very important. Next slide, please. So what are we doing now? The physician leading the program is working in collaboration with our division and metabolic syndrome, trying to find a way to improve and upscale this program to go beyond being within our region to being a provincial program. And this includes discussion on how we can build on framework of this program in our patient care network projects. And also we are trying to work with funders on how to raise money to be able to sustain this program for a longer period. So some of the things we are doing at this point is modifying the program to be more cultural sensitive, especially if it has to do with First Nation and Indigenous cultures. So we're trying to see how we can factor their lifestyle and their activities in this program, create a bit of flexibility just to make sure we accommodate as much participants as necessary. And we're also building the best innovation on virtual and in-person visits. There was some, especially on a period like this that COVID has made some changes. Especially some participants that have issues with transportation. We are working on how we can even have answers with them that is virtual, not requiring them to come in for an in-person visit. We are building partnerships and we are sending applications for funds to be able to move forward with having a financial support that is required. We are also modifying the program to include both prehab and a rehab. The rehab is important because what happens when a patient comes down with cardiovascular disease? In my community, it's about 4 hours drive to get a cardiac rehab. Having a patient like this in the community already and trying to build on that will help us to provide that same service in our community and save our patients the cost and the time of traveling for a long period. We are also involving more GPs on the program and also including specialists on the program, trying to make it more robust for patients and trying to have a way to move it forward to be a more of a sustainable program. Yes, so this is what we are doing now. We are building a mosaic approach to sustain Change BC, to upscale it, hoping that it's going to be a provincial-wide program one day. Next slide, please. So thank you for the time, and we are here to take your questions and your feedback. Thank you.
Thank you so much. That was amazing. We do have a couple questions. Feel free to pop a couple more in. We have a few minutes. So first question is, do you have a sense of the percentage of family practitioner physicians who are using this model of care?
Okay, so I don't have a number for that, but I know in the communities, the 4 communities that actually piloted this program, most of the family physicians are aware of that, and they are trying, to see how they can incorporate it into their practice. But there are challenges because this is a team, so you need a dietitian and you need a kinesiologist. So it's not a program that only a family physician can implement. And that's one of the reasons we are working to see how we can get this incorporated in our primary care network. So it is a division program. So we have more than 100 family physicians in our division, which are open to be part of this. But we need to have other teams, like we need to have a dietitian and kinesiologist for this to be able to work.
In my community, there is 4 different practices, A, B, C, and D. And we selected patients, about 10 or so, I think, from each practice. And so each physician knew about the program and would do the follow-up. But there was 2 of us here who were doing the organization of the blood work and things like that.
Great, okay, thank you. So I think this question about patients' reaction to the program was shared. So jumping to the next one, would the availability of virtual RD make sense and work in your communities?
Yes, even during the pilot program, there is a virtual component of that because, we have a dietitian and, she won't be able to travel all the way because, the communities are wide apart. So some of the patients we attended, virtually, and that was even before, this, COVID and, this promotion for virtual. So we so much know and believe that it is possible.
For my community, due to poverty, I think we've really failed in doing a lot of Zoom appointments since COVID. So I think that the telephone has been really popular. So I think that if we were able to implement the program longer term, people might be even more receptive to phone calls from multiple providers for appointments than they were before, because now they're so much more accustomed to communicating that way about health concerns.
Great. Thank you. Yeah, it's interesting to see what the impact of the last 6 months to 9 months has been. So how about we do one more, and then maybe the last question you guys could just answer in the chat while I wrap up. Does that sound good? So uptake, what percentage of patients with metabolic syndrome wanted to pursue the program?
I wouldn't be able to give a number, but I know that there was a lot of interest. There was some skeptics about one of the responses and barriers was distrust with the healthcare system. So one of the things that came up was worries about being a part of a study, and a study that might just happen for a year and then leave with nothing ongoing in the community. But other than that, one thought that people seem to be very interested. And unfortunately, there was an exclusion criteria of a BMI over 35, which for my community did stop a lot of people who are interested from participating. So I'm hoping that the change in that stipulation will allow a lot more people to participate.
Great. Honora, do you have anything to add there before we wrap up?
Yes. Just as Justin said, at the beginning, period, some people were like, they are not sure what they're getting into. But even up to date, I see how people that come into the clinic asking, is this program still going on? Can they be around into the program? And that was because, they have seen the testimonies. We structured it in such a way that, the participants had this, free pass to go into the range of activities. And, that is a bit attractive to them. And the exercise programs that are involved are what participants can do at their home. So they are being empowered, to do things on their own. And, the testimonies from the participants about the dietary support, and other things actually entice others and, to become much more interested on that. So I don't have, the idea of the percent, but I know most of the people that we are not interested, before we started are now interested. And we are hoping that, if we can get the funding and the support that is needed, that we have more people engaged in the program.
Awesome. Thank you. Thank you. Okay, so we are at close to a minute away. So thank you, Jocelyn, Honora, and Danielle. And thank you everyone for carving out the 60 minutes and being here with us, and for your participation. And then of course to our amazing guests for sharing the inspiring work. And I think it's always good to step away and take some time to really look at what everyone else is doing, and especially when it's the amazing work like we've seen today. So thank you. As always, we would love to hear your feedback. So Sean is going to be popping our evaluation survey into the chat box, as well as emailing it out after this session. And we are always looking for feedback. So please do take a couple minutes to fill that out. And then just a quick reminder before we sign off that the Type 2 Diabetes Dialogue is less than a month away. And we're really looking forward to continuing this conversation at that dialogue session, and look forward to having you all there. So thank you for your time and have a great afternoon.
Bye.
Thank you.
Bye.
Thanks, everyone.
Thank you.